If y'all want to go get it, I'll give you about 15 seconds. For all of you on the video, I did just pause. I went to upload. Y'all need to go to the LINK in my bio and go over to the STAN store to get your class documents. Okay? Guys, I highly suggest you remember these drugs for the Nclex. You may not remember all the drugs. These drugs, these classes, the examples of these certain drugs, the action, the nursing considerations, you need to know these drugs. I can guarantee you that you will see more than one of these on your Nclex. I can guarantee you. And for you guys that have recently, for you all that's recently taken your Nclex, I guarantee you that you saw some of these drugs. Now, the Nclex does go on a CAT scale. Back when I was taking the Nclex, it was different. But basically, it's kind of got the same. What do you want? Okay, let me get a wipe so I can wipe you. It's kind of got the same. It's kind of got the same type of thought. When they are testing you, if you're doing really, really well in one area, they're not going to keep testing you somewhere where you're doing well. Okay? They'll continue to give you questions to give you the opportunity to pass the test, but they're not going to keep. What is wrong? Here, wash your hands. It hurts because you got salt in it. Hang on, y'all. I got to get my kid upstairs to her sister. Hang on. Carmani. Get Montana. Get Montana. Watch her for me. Go get Carmani. Carmani, go in my room with Tana. Hold on, guys. I'm coming. What are you doing? Go upstairs. Go in the room. Aren't you coming? No, I'm recording my class. Get her for me. Sorry, y'all. I'm having toddler problems right now. She got some salt in her. She got salt in her from potato chips in her little boo-boo. All right. So you need to know these drugs. You need to know the examples. You need to know what class they are, the action, the nursing considerations, and when to hold them. Okay? ACE inhibitors. When you guys hear the word ACE inhibitor, you should automatically know that it should not be the treatment, first line treatment for African American people and the cough, the crazy barky cough. That's something that should ring your bell when you hear ACE inhibitor. Okay? So lisinopril is used a lot. And that'll be the medication that a lot of people, end up having this crazy cough. It's not just a regular cough, y'all. It is a barky, awful cough. Okay? So Catepril, lisinopril, I never say these right, enalapril, okay? They are angiotensin blocker number 2s. They lower the blood pressure and they lower the afterload. All right? And that is a dry cough, right? If that happens, you want to switch them to an ARB, monitor their potassium for hyperkalemia risk, and monitor renal function. You want to hold it if they're systolic, the top number, blood pressure is less than 90, or if the potassium is greater than 5.5. If their potassium is greater than 5.5, you need to be fixing that. All right. So the next is an ARB or your Sartans. Okay. They wanted to put my husband on lisinopril, and I said, So we took losartan instead. Losartan, valsartan, olmesartan. If I said it wrong, I did. They block angiotensin 2 receptor. So an angiotensin 2 receptor blocker. What do? They lower the blood pressure. They do not have the cough side effect, unlike the ACE ones. You still want to monitor for potassium and renal function. Same goes. Systolic less than 90 or potassium less than 5.5. Or greater than 5.5. I'm sorry. I will tell you that in the real world, a lot of the doctors, especially newer practitioners or physician assistants, they'll say if it's less than 100 to hold it because they're playing on the safety side. However, again, if I were you in a real life situation, but for Nclex purposes, 90 is your number. I would definitely say, hey, doc, this person's blood pressure is 98 over 50, 59. But they're resting in bed and laying there peaceful and they're not doing anything. However, I know if I don't give them this medication, X, Y, and Z might occur. Okay? Before you just decide to document that you held the medicine and moved on. You always want to check. Okay? It could be a no-brainer sometimes, but you still want to check. Cover your behind. All right. Calcium channel blockers, CCBs, amlodipine, ditilazim, verapamil. They lower the heart rate. Okay? They lower the heart rate. They lower the blood pressure. They cause vasodilation, and that's how they work. Monitor the heart rate and the blood pressure. They can also cause you to be able to not poop, constipation. You avoid grapefruit juice with your calcium channel blockers. Guys, both of my tests, and I remember this over 20 years ago, my LPN and RN, I had questions about grapefruit juice. You know how I remember that? Because I missed them. I know I missed them. All right? Because I said something real good and stupid. I can't remember the answer, but I missed them. Okay? Heart rate's less than 60. Ditilazim and verapamil. You're going to hold it if the heart rate is less than 60. All right, moving on. We're back to digoxin or lanoxin. My granddaddy took this. My papa Kenneth took digoxin. He had a heart disease called idiopathic cardiomyopathy. Okay, he took dig. He only had 20% of his heart working. What does dig do? This is how I remember this drug, y'all. That's why I'm talking about my granddaddy. It increases the contractility. It decreases the heart rate. Okay? So in all, this decreases the workload of the heart and makes it work better at the same time. Okay? Because it increases contractility and decreases the heart rate. You need to make sure you're taking an apical pulse for 1 minute before giving it. Potassium. If your potassium, see that number again? 3.5, it potentiates for toxicity. The therapeutic drug range is 0.5 to 2.0. Pulse is less than 60, you hold it. If the dig level is greater than 2, you hold it. If the potassium is less than 3.5, you hold it. Okay? Nitrates, aka nitroglycerin. Y'all, just so you know, if you ever get nitro paste on your hand and you don't need, it's going to give you a butt whopping headache. Just remember that. Nitro will give you a butt whopping headache. Okay? So, nitroglycerin, or also known as NTG, or isosorbide. Vasodilation. It decreases the preload and it helps with chest pain or angina. Okay? It'll also save your life if you're having a heart attack. Okay? It causes headaches. It says headaches are common. Boy, it causes a headache. Store in a dark glass. That's why they come in them little bitty glass bottles. 3 doses, 5 minutes apart for chest pain. If your systolic blood pressure is less than 90, you should hold it. If you've had a recent PDE 5 inhibitor, such as Viagra. So if your patient's been playing and dilly-dallying in that medication that makes their boy parts happy, you do not want to give them nitroglycerin. It's not going to be a good outcome. Just don't do it. Trust me. Not that I've ever done it before, but people come to the hospital and they're like, oh my God, I took my nitroglycerin with my Viagra and X, Y, and Z happened. Okay? Don't do it. Statins. Statin, such as atorvastatin, simvastatin, or rosuvastatin. I can never say that right. It's Crestor. They lower your LDL cholesterol. You want to take these at bedtime and monitor for enzymes such as your liver, your LFT, right? Myopathy risk, muscle pain, and weakness. If someone has liver disease, if they're pregnant, it's a category X. You do not give people that have liver disease or if they are with child a statin because it is a category X. Okay? It's not a maybe. It's not a risk versus benefit. It's none of the above. You don't do it. It's a category X. Hello, guys. My name is Coach Shay. I'm the R Influencer, and I am giving you Nclex tips. These are drug classes that are the top drug classes for the Nclex. All right? So I'm going to give y'all the Nclex vital sign rules for cardiac drug hold. Beta blockers and digoxin, you hold if the heart rate's less than 60. You check apical pulse for an entire minute. Okay? ACE1 and ARBs, you hold if the systolic blood pressure is less than 90 or if the potassium is greater than 5.5 and notify the doctor. Nitrates, hold if the systolic blood pressure is less than 90. You never give with Viagra. It can cause fatal hypotension. Okay? Loop diuretics, you always, let's back up, y'all. I'm going to go back to loop diuretics in just a sec because we skipped it. For loop diuretics, you always replace potassium. You give them with a potassium supplement or a potassium-sparing diuretic like spironolactone. Okay? Dig toxicity. Your signs are bradycardia, which is a low heart rate, nausea and vomiting. Yellow and green halos is what you will see on the Nclex. Yellow and green halos will be on your Nclex. I suggest you remember that when it comes to dig. What, baby? Back to loop diuretics, furosemide or Lasix or bumetanide. I say I'm wrong because I'm talking fast. They increase your urine output and they decrease your fluid overload. So they help you excrete fluid that's overloading your system. But they also are known as a potassium wasting diuretic. You have to monitor potassium. If somebody is on IV Lasix and you're in the hospital, we give IV Lasix all the time, especially in the ICU. You want to ensure that you are monitoring their potassium because hypokalemia and hyperkalemia are both dangerous. If you have someone that is on a Lasix IV or a push, or drip or push, either or, you need to make sure that you are watching that potassium closely. Even if they're on oral Lasix, you should monitor their potassium always. Lasix, potassium, period, point blank. I's and O's, daily weights and ototoxicity with high doses. If the potassium is less than 3 or the systolic blood pressure is less than 90, you do not give it. Lasix will bottom your blood pressure. Okay? Your respiratory meds that are important. Your SABAs, S-A-B-A. You got your SABAs and your LABAs. Does that ring your bell? Because your pharmacology teacher should have taught you about SABAs and LABAs when it comes to respiratory. SABAs are your rescue inhalers. If you want to know how I remember SABA, because it's rescue, because the word shit starts with an S. I call them the oh shit meds. Okay? They are rescue inhalers such as Ventolin and ProAir, also known as albuterol. They are bronchodilators. They give you immediate relief. You use them first in an acute attack. They will cause tachycardia and tremors. That is a side effect. It's not an adverse reaction. You teach proper inhaler techniques to your patient. LABAs, L-A-B-A, they're your maintenance. I learned that by saying, not that they're not important, but they're lower on the totem pole. So L-A-B-A, it's a low. So LABA, it's your maintenance. All right, like your salmeterol, okay? Or your formoterol. I never say stuff right. They reduce airway inflammation. They sustain bronchodilation. They're not for acute attacks. You always use with an inhaled corticosteroid, ICS. Okay? Next on the list is your inhaled corticosteroids, ICS. You got your fluticasone or your Flovent and your budesonide. These reduce airway inflammation. You want to make sure your patients are rinsing their mouth after use. That will be on your Nclex. It will prevent oral candidiasis. I can't say it. Thrush. They're not for acute attacks. Then you got your combo inhalers like Advair, okay, or Symbicort that cost a whole lot of money. Yep, they sure do. So you got your ICS plus your LABA combined in one, but it is cheaper for patients in the long run that have airway restricted. It's not showing past this. Y'all, my husband is trying not to be on the live stream. So he's over there like, what? Look, it's literally not showing. Everybody tell Mr. Carter y'all can't see him. He don't like being on camera, y'all. All right, babe, it's not showing anything past the computer. For you two that are with me, hello. Hi. Tiana. Y'all, I'm not looking at the screen, so I'm literally behind it because I want you all to be able to see this, okay? And I'm recording for our folks for the recording. All right. Moving on up. I don't know why my husband thinks I can read like this, but I can't. Okay. So now we got we just talked about our combinations. Anticholinergics. I love anticholinergic drugs. I don't know why, because I hated them in school. They took me forever to learn the anticholinergic drugs, okay? So you have your Atrovent and your Spiriva. They bronchodilate via the anticholinergic effect. Anticholinergic causes you to dry up. They also will cause you to be constipated. They dry you up. You can't poop. Dry mouth, urinary retention. They use them in COPD. They're not firsthand use for asthma. Okay? I be forgetting I'm recording, y'all. Excuse me. I'm over here got my legs propped up and everything. All right? Moving on. Guys, these drugs, I specifically made this for you guys, and this is literally focused at the Nclex. Even after all these years of taking my Nclex, I still remember these things that were on there. All right. So, our drug class, again, I never say stuff right. Methylxanthines or theophylline. I know how to say that. Bronchodilation. It has a very narrow therapeutic index. The therapeutic level is between 10 and 20. Toxicity, tachycardia, seizures, and nausea are key nursing considerations for theophylline. You need to know that. All right. Leukotriene modifiers or Singulair. They block inflammatory mediators. So they help with inflammation. So your little nursing home patient, they get Singulair and they run out of it and nobody refilled it and you're like, oh, okay, it's not a serious drug. Yes, it is. They need that. It helps with the inflammation of their airway and it helps them breathe better. Orally, once a day. Black box warning, mood and behavior changes in children. Let me just tell you, that is so very true. Now, this is going to be on your Nclex because there is a specific order into which you give inhaled medications. Okay? Albuterol is a SABA, that rescue med, the oh shit med. Use it when your symptom hits. Why? Because you're probably having bronchospasms, and that's known as an acute attack. Your fluticasone or budesonide, that's an ICS, right? Your inhaled corticosteroids. It's a controller. You use it every day to prevent inflammation. Okay? Always rinse your mouth after the ICS. Okay? Steroids taste like garbage. It prevents thrush and oral candidiasis. Thrush. COPD versus asthma. COPD patients should not get high flow O2. Why should COPD patients not get high flow O2? Because hypoxic drive risk. Theophylline toxicity. Tachycardia plus seizures, a narrow therapeutic window. It's 10 to 20. Guys, That will be on your Nclex. I specifically remember that. Neurological medications. We're almost done, guys. So you got your opiates, morphine, oxy, dilaudid, fent. Monitor your respiratory rate. You hold if it's less than 12. Constipation. Always give a stool softener, and it creates a falls risk. Every one of my patients that take opiates in the ICU, I make them high falls risk. Why? Because they are. All right. The antidote is Narcan. Guys, if you're not a nurse, you should know what the antidote for opioid overdose is because of everything that's going on in the world. NSAIDs for your non-steroid anti-inflammatory drugs. NSAIDs. Hello, guys. My name is Coach Shay. I'm the R Influencer. We are talking about medications that will be on your Nclex. If you do not have this this document and you would like it, please go to the LINK in my bio. It's in there. It will say purchase, but it is FREE. Ibuprofen, Toradol, naproxen. They cause GI bleeding risk. You give them with food. They can also affect your kidneys. You need to avoid in elderly patients and if they are on anticoagulants. The max dose of Toradol use is 5 days. We do not, even though Toradol is the bomb, you do not give ketorolac for over 5 days. Then we got your anticonvulsants, your Dilantin, your Keppra, your valproic acid. Your phenytoin is therapeutic between 10 and 20. This can cause gingival hyperplasia. Okay? IV is less than 50 milligrams per minute. That is the dose. Do not stop abruptly. You can have rebound seizures. Okay? Benzos. We talked about benzos. Lorazepam, diazepam, Valium, Ativan, diazepam, midazolam, all those things. Respiratory depression, fall risk dependence. Do not stop abruptly. The antidote is, you need to know this, flumazenil. I never say it right. Or Ramazicon. I say Ramazicon, but the flumazenil, Ramazicon, that's your antidote. Then you got your anti-Parkinson's medications, your Cinnamate, your levodopa, carbidopa. Guys, do not jerk around with patients that take this medication. It has to be given on time every day at the same time. That helps it be most therapeutic for your patient. And hope and pray that you're never a Parkinson's person that suffers from Parkinson. Give it 30 to 60 minutes before meals. It's the on-off phenomenon. Do not stop abruptly. It can cause dyskinesia, which is involuntary movements. All right? It's a dose-related side effect. SSRIs are antidepressants, such as Prozac, Ceterolene or Zoloft, Celexa or Citalopram. 2 to 4 weeks for full therapeutic effect. Monitor for suicidal ideation in patients less than 25. Guys, that's a real deal, Holyfield. I worked with adolescents in a psychiatric setting. This is real deal, okay? Serotonin syndrome. This is an Nclex watch. Serotonin syndrome, hyperthermia plus agitation plus clonus, okay? You want to monitor these patients for serotonin syndrome. Typical antipsychotics. Typical antipsychotics, such as Haldol, EPS, akathisia, dystonia, tardive dyskinesia. You treat EPS with cogentin. You need to know that. How do you treat EPS? With cogentin. Neuroleptic malignant syndrome, or NMS, hyperthermia plus rigidity plus altered level of consciousness. That is an Nclex watch for typical antipsychotics. Haldol is a very common drug that we use. Okay? EPS is treated with cogentin. All right? So, the rules for the Nclex for neurological drugs. Opiates, if the respiratory rate is less than 12, you hold it. Plus, you're probably going to give Narcan and call the doctor. I would call the doctor if it's like between 10 and 12. If it's less than 10, I'm going to give the Narcan, then call the doctor. For the Nclex purpose, less than 12. Narcan, call the doctor. Dilantin or phenytoin. Therapeutic is between 10 and 20. It does cause gingival gum hyperplasia. It's a classic side effect. It's also known as the gingival hyperplasia. That is a classic. That's a classic side effect, guys. They will have that on there. Okay? SSRIs takes 2 to 4 weeks for full effect. You tell your patients this so they don't stop them too soon because they'll be like, oh, it's not working. I'm not taking it no more. Well, it ain't working because it ain't been long enough. Antipsychotics cause EPS, movement disorder. You treat it with cogentin. Serotonin syndrome, hyperthermia, which is a low temperature plus agitation plus twitching. You stop the drug immediately. Okay? Now, we're moving on down to the endocrine meds. We're almost done. All right. We have oh, this is the last. Yeah, this is the last section. All right. So we're going to talk about insulin. Insulin is important, y'all. Insulin. You won't see how many times that I see people jerk around and play with insulin. Insulin can kill you quickly. Insulin can kill you quickly. So, you want to make sure that you know the difference between, and you want to know what it means. You got rapid, you got intermediate, you got long-acting insulin, right? You need to know what that means. For example, I'm not reading to you right this second. If I give somebody 40 units of Lantus at 9 o'clock at night, and I'm working the night shift and come about, I don't know, do that 4 a.m. blood sugar check, and I notice that their blood sugar's right, it's teeter-tottering on that low number. I'm probably going to give them some juice because guess what? It's going to probably keep getting lower. All right? So you need to know things like that. So your rapid-acting insulin, such as your Humalog or Novolog, it has a 10 to 30-minute onset, 30 to 90-minute peak, and 3 to 5 hour duration. These are medications that you give with meals within 15 minutes of eating. That's on the Nclex. A lot of places you work will say within 30 minutes. You give them within 15 minutes. Your short-acting insulin, you got your regular Humulin R or Novulin R. 30 to 60-minute onset, 2 to 4 hour peak, 6 to 8 hour duration. 30 minutes before meals, only insulin given IV. You will never give insulin IV other than R. Okay? Intermediate acting. Your NPH. Your Humulin N or Novulin N. 1 to 3 hour onset, 6 to 12 hour peak, 16 to 24 hour duration. This is your cloudy insulin. They peak 6 to 12 hours. Hypoglycemia is a risk. Okay? Hold on, y'all. Thank you for the follow. Y'all share out the live. All right, long acting. We got your Lantus and your Levemir. It has a 1 to 2 hour onset. It does not have a peak. The duration, it lasts 20 to 24 hours. Never mix with other insulins at the same time daily. Do you understand? Because they were overlap. Okay? Then it'll have like a stronger effect because they're getting more of the medication. Then you have your combination, your 70-30. This is NPH insulin plus regular. The onset varies. The peak has a dual peak, and the duration varies. It's 2 different insulins. 70% NPH plus 30% of regular. It's given twice daily with meals. This is exactly how I remember my insulin. Clear before cloudy. The E comes before the O. So they're both CL, clear, CLEAR, cloudy, CLO. The E comes before the O. Clear before cloudy. Okay? R before N. I know that's backwards, but regular is clear. Drawn before the NPH is cloudy. Clear to cloudy. Write it down, take a picture, tattoo it on your brain, put it on your mirror. If you're not careful with insulin, you will cause a fatality. Okay? All right. Only regular insulin can be given IV. All others are sub-Q only. Lantus, you never mix it. It does not have a peak. You give it at the same time every day. Hypoglycemia is less than 70. Give 15 grams of fast carbs. Recheck in 15 minutes. If unconscious, give them D50. IV or glucagon IM. That's what they call the Somogyi effect. Nighttime hypoglycemia leads to rebound morning hyperglycemia. Decreased evening dose. Dawn phenomenon is early morning hyperglycemia from growth hormone surge. You increase your morning dose. You will need to know about the Somogyi effect and the dawn phenomenon. You need to know all that, to be honest. Everything is fair game in that. And that yellow, if something is yellow on this form, it's all fair game for the Nclex. Okay? Moving on. These are your oral anti-diabetics. We're almost done, guys. You got your metformin. That's for type 2 diabetic. Type 2 diabetics is the first line oral agent. Hold 24 to 48 hours before contrast diet. Why? Because of lactic acidosis risk, GI side effects. You take them with food. They give you dye when you get like your exams and stuff, and they're both hard on your kidneys. So it can cause lactic acidosis. Synthroid, hypothyroidism replacement. Take on an empty stomach in the AM. Do not take with calcium or iron. It can cause toxicity. Hyperthyroid symptoms are your signs. So do not, if you're in a nursing home working and your patient gets 30 medications, do not be like, oh, I'm just going to do my 6 a.m. meds at 9 a.m. No. You give them Meprazole and Synthroid at 6 a.m. for a reason. Do not give it with everything else. There are so many side effects, okay? Then you got your methimazole or your PTU, which is your hyperthyroidism. That's what it's used for. You monitor for agranulocytosis, which is a fever and sore throat. You stop the drug if that happens. PTU is preferred in pregnancy, guys. PTU, preferred pregnancy. PTU, PP. Pregnancy, PTU. Prednisone and corticosteroids. Inflammation and autoimmune and adrenal insufficiency is the use. Give with food. Do not stop abruptly. It can cause an adrenal crisis. Causes hyperglycemia plus immunosuppression. You never stop a steroid abruptly. It's dangerous. All right. Your sulfonylureas like glipizide and glyburide. Type 2 diabetes. It stimulates the insulin release. Okay. Hypoglycemia risk. Give with meals. Use with caution. In elderly, it can cause prolonged hypoglycemia. Your elderly patients, you know, as we get older, our kidneys may not be working. They can have polypharmacy. They can have a buildup of things, all types of things. That's why you see a lot of toxicity with elders. Okay? All right. We already went over the antidotes for your opiates. We talked about that. Opiate antidote is naloxone. Ativan is romazicon. Coumadin is vitamin K. Heparin is protamine sulfate. Dig is Digibine. Tylenol is Bucamist. Organophosphates are nerve agents. Atropine plus prolidotixine, which is called a 2-PAM. Magnesium toxicity, you give calcium gluc. Heparin-induced thrombocytopenia, also known as HIT or HIT. Argatroban or Lepridin. Iron overdose, you give deferoxamine. Okay? Y'all got this. It's available to you. You can go get it because I can read it to you. You're not going to memorize it. Antidote mnemonics. Know these. Okay? Opiate, Narcan. N for Narcan. N for no breathing. Benzos. F2 flumarizine. F for forget the benzo. Warfarin, vitamin K. W and K. Warfarin killed by K. Heparin, protamine. H and P. Heparin's protamine pal. Digoxin is Digibine. Dig gets bound by Digibine. Tylenol, NAC, is also known as Mucamist. NAC ataxia-acetaminophen. Mag toxicity is calcium gluc. Okay? We talked about this drug toxicity, theophylline, talked about that. All right, this is the end of it. Nclex rules. Memorize these. Always check vital signs before giving cardiac, antihypertensives, or opioid medications. Hold and notify the provider. Do not just hold silently without reporting. Do not just hold silently without reporting. Do not just hold silently without reporting. When in doubt about a medication, look it up before giving. Call pharmacy, get your drug book, call the doctor, do whatever. This is always the safe answer. The Nclex is a safety exam. The first action for a medication error is to assess the patient after giving the medication. PRM medication, assess the patient before and after. Patient teaching, always include what side effects to report to the provider. Narrow therapeutic index drugs, digoxin, lithium, dilantin, theophylline, and coumadin. You monitor the levels. Okay? You guys can read the rest of that. Make sure you go to the LINK in my bio and get your pharmacology packet.